Thank you very much, Arthur. Is there any question in the audience? Jennifer?
Thanks for your talk, Art. Are you surprised that all those numbers that Christer showed yesterday about the tidal volume chosen in 180 patients, that the mean value is around 6 or 7 ml per kilo in babies and adults? Isn't that kind of ironic considering the 6 ml per kilo Art's nuts?
I know, it's interesting. What's ironic is that, a lot of people have complained that the 6 ml from the Ardsnet study was completely arbitrary and and yet on average came out the case. But the key here is that that's on average. And in the Ardsnet study, everybody gets 6 ml per kilo. Here, like the numbers are a little lower, but in other studies they're around 6, but there's a fair bit of variation. And in animals and in humans, the variation can be anywhere from 4 to 10 ml per kilo. So that's why it's possible that the patients are doing a much better job than us at setting their tidal volume.
Nice presentation, Art.
What else are you going to say? You work for me, Christer.
Can I get a raise? I think this is like as we saw in this study when Lucas was with us. I mean, it's really like astonishing, like that the animals choose these low levels. But we have done since then like studies where we try to keep them with one lung and lung injury for 6 hours. Doesn't work. They die. 3 hours, they're gone. So there is a limit. Like what I tried to show yesterday. And I think that study, even though that study was not very good or well done, like statistically, like epidemiologists are very upset with that study about the paralysis there that you showed. But I think it's exactly like what Jukka said this morning. Like the VCO2 does not permit at some point, you can just not keep your CO2, take it out of the body by ventilation without injuring the lung. And I think this is like exactly what it shows. 6 ml for an average group of patients is probably the right thing. But when it goes to a certain extent, there is no other way than just either put them on ECMO or just put the volume even lower. But I think there is this cutoff point. And with spontaneous breathing, the risk with that one is that when that drive goes ballistic, I would call it, then volume starts to increase to a point where they become more and more injurious. And I think that's for everyone who works with spontaneous breathing. It's like really to watch out for those situations when the patient actually loses the control over his tidal volume.
Yeah, exactly. And that's where in that feedback loop I was talking about.
And we still don't know when that thing really occurs.
And I think you're right. I think there are going to be some patients that perhaps we have to go to ECMO. We have to do something a little bit different. I mean, the smallest tidal volumes with high frequency ventilation, maybe ECMO, maybe not that, they're going to die.
Yeah, but still, to follow up on that, would you be happy to accept a little bit higher tidal volumes, say 8 ml per kilogram? Because we saw the pictures this morning, you recruit more alveoli with spontaneous efforts. So perhaps you can accept a little bit higher tidal volumes, because that's what sometimes happens with NAVA. You see, it's not very high, but we have the patient with 7 or 8 ml per kilogram. Yeah. Mm-hmm.
Yeah, the question of what the right tidal volume is difficult because, quite frankly, it's not tidal volume per se that probably causes the injury. It's sort of lung stretch. So in some patients, 8 ml per kilo is not going to cause much more lung stretch. Some patients, it's going to cause huge lung stretch, and it also then depends on the PEEP level, et cetera. And that's why if in fact patients do have their intrinsic mechanisms, protective mechanisms, and that's a big question, quite frankly, when you have acute lung injury. That they could tell us, yeah, 8 is okay. I'm okay with 8. My receptors are saying I'm not causing more injury, if that hypothesis is correct.
Thank you. Last question, Christer.
I think this also it's shown that this also works in the human, because a paper from Samir Chabert in late ARDS patients, he showed that the patients with during NAVA, they had a tidal volume of less than 5 ml per kilo about 12% of the time, on average for all the patients included. And compared to when they were on controlled mechanical ventilation, their PCO2 was much more improved, and I interpreted that the distribution was totally different, and this also was a big factor in maintaining the PCO2 in the patients.
You know, it's interesting if you look at a wide range of animals, mammals, from very small to elephants. I think March Tenney published that you know, the mean tidal volume is about 6 ml per kilo across animals that range from, you know, very small to 1,000 kilos. You know, turns out, not coincidentally, there must be something there in terms of the mechanics, in terms of the, you know, if you look at transpulmonary pressure is what's important, because it's the same across different animals, that it scales with the weight.